Good afternoon. I forget the time of day, it's Saturday. Thank you guys for having me. I am a Southern California native, and it's nice to not have to leave Southern California for conferences, so it's good to be here. And I was talking to Dr. Jamil, my sister is actually an attending at San Diego, not very far from you guys, and so I got to stay with her and visit San Diego a little bit yesterday, which was nice. The weather is definitely more temperate here than it is in LA, so I'm going to enjoy it while I can. But today I want to talk about sort of the pre-ECMO ventilator management of ARDS. My research is in patient selection for ARDS, and part of my role at UCLA is evaluating all of our referrals for bridge to recovery VV ECMO for ARDS. And so I'm happy to share some of that today. So what will we talk about? Very briefly, you had a lot of talks about the mechanisms, benefit of ECMO and ARDS, describe some of the evidence-based pre-ECMO ventilation strategies, identify when to refer people for VV ECMO, and then finally apply some of these guidelines to patient care. I just said I was going to talk about all the things we could do before ECMO, but I think it's important to couch this all in the fact that there's still some debate about whether or not ECMO is standard of care. And so this publication by one of my former attendings was put out about 6 years ago, where people are still asking whether or not ECMO has moved from salvage to standard of care. And so I think given that that's still an ongoing debate, it's incumbent upon us to use all the things that we know work while we evaluate people for ECMO. So why does ECMO work, and if it does work, why shouldn't everyone get it? Well, those of us who manage patients on ECMO know that it's very time, labor, resource intensive. So not only does it require specialized equipment, but specialists, so nursing, perfusion, physicians. And so it's not something that we can just say, well, we know how to do it, so everyone should get it. We know that that would essentially bankrupt the system in terms of our ability to take care of other patients. So we think ECMO works in many ways. So this is one of the papers that another former attending wrote in the Lancet, if I remember correctly. Oh no, this is JAMA. And I refer basically every trainee that I work with to read this paper because it's a great overview of how ECMO works and why we think it works. But I want to draw your attention to this third pillar, which is minimizing lung stress and strain. And we think that ECMO allows us to decrease tidal volumes, plateau airway pressures, respiratory rate, decrease ventilator-induced lung injury. And so the point here, though, is that even though ECMO is able to do all these things, we can accomplish these things before putting people on ECMO, and we should because we know from the evidence that those things do work in terms of mortality. And so I hesitate to put this slide up because I'm talking to a bunch of RTs asking whether or not mechanical ventilators matter. But if ECMO works so well, one might ask, well, why don't we just skip the ventilator entirely? Well, one, I said that we simply don't have the capacity to do that in our healthcare system. But two, we also know that the ventilator works if used correctly. And so there are things that we can do on the ventilator to even potentially prevent people from having to go on ECMO. The other reason is that ECMO is not benign, right? So even though we have all these great success stories of people recovering on ECMO, there are a myriad of complications that people experience on ECMO. So everything from neurologic, I remember, unfortunately, one might call it traumatic memories of all of the people we had on ECMO during COVID who suffered intracranial hemorrhage. There are pulmonary complications, there are cardiac complications. I still remember one of our 56-year-old patients with ARDS who died of cardiac tamponade because of the ECMO cannula position. There are renal complications, infectious complications, and then the circuit-related complications. So ECMO is great, but it's not something that comes without risk. And so again, it behooves us to do everything we can to make sure that that risk does not outweigh the benefit by doing all the things that we can before. And so I'm going to talk about a lot of things that have been highlighted in the most recent ATS guidelines in 2024 that I believe both Drs. Jones and Odish had spoken about in their talks. And I want to point your attention to this nice infographic. I love infographics in papers. They're the easiest thing for me to just remember. But if you look at the 6 interventions in the conditional and the strong recommendation group, 3, arguably 4, if you include neuromuscular blockade, are focused on the mechanical ventilator. And so why do we care about these recommendations so much? Well, we care about them because good ARDS care can really obviate the need for ECMO. And so this is the LungSafe study from 2016 that looked at about 24 patients in ICUs across the world and really examined how well we were sort of keeping with evidence-based strategies in ARDS. And at the time, the data was not great. So 60% of people, I apologize for the text being a little bit small, but 60% of people with ARDS got none of the adjunctive strategies that they surveyed. And that includes these 4 strategies that I'm going to talk a little bit about, including neuromuscular blockade, recruitment maneuvers, prone positioning, and ECMO. What was even more concerning is that things like prone positioning, only 8% of people got prone positioning. This paper was published in 2016, which was 3 years after the PROSEVA trial, which was a decade after meta-analyses showing that prone positioning is beneficial in ARDS. And so they re-surveyed about 5 years later, and the numbers weren't much better. So thank goodness, high-frequency oscillatory ventilation went down a little bit. It should be 0, but we'll take what we can get. Prone positioning, if anything, went down as well. What would be interesting would be to see this chart now after COVID, when we sort of dug a little deeper in our toolbox and started using anything that we could use. But even 5 years after, the numbers hadn't really changed, and this is now even farther from studies showing all these things that work. So prone positioning at this point this was almost 8 years from PROSEVA. Neuromuscular blockade, this was about 2 years after the Rose trial. And then this is about a decade after Eolia, which technically was a negative trial, but as Dr. Jones had mentioned, based on the actual data, suggests that ECMO does work. So I'm going to talk a little bit about the topics that come up for us most at UCLA when we're evaluating patients for ECMO, and some of the questions that come up in terms of what should we be doing on the ventilator to both optimize the patient, just from their ARDS care, and also sort of maintain their candidacy for ECMO. And so one question that comes up is just the very basic pressure versus volume ventilation. Does this even matter? So this has been asked a couple times. This is a Cochrane review from, I believe, 2015 that looked at 3 RCTs. That was about 1,100 patients. 2 of the RCTs looked at the 28-day ICU mortality and found a relative risk reduction of 16% in mortality for pressure control ventilation versus volume control. And this encompassed about 1,000 patients. But when they pooled the results of this, they basically concluded that there was no significant benefit. And if you look at the individual studies, neither of their estimates actually were significant. So I think you have to take the one positive study with a grain of salt. This was followed by a randomized control trial where this group in particular looked at pressure-controlled spontaneous ventilation versus assist-controlled volume ventilation. And they looked at 700 patients split pretty evenly down the middle to the pressure-controlled spontaneous versus volume control. Their primary outcome was 28-day ICU mortality, this is 28-day hospital mortality, that's a typo. And they found basically there was no difference in the primary outcome, there was no difference in ventilator-free days, in the duration of mechanical ventilation or ICU length of stay. And so our general recommendations here is that it doesn't really matter what mode you're using between pressure control and volume control, as long as you're adhering to sort of the low tidal volume ventilation guidelines. There have been other studies that have looked at APRV versus and have also found no real difference. Maybe you get a little bit better oxygenation with APRV, and maybe you have generally higher mean airway pressures, but still no difference in mortality, which is what we all typically care about. And then this is just the Kaplan-Meier curve making the point. So this is one of those things that sort of counts as a mechanical ventilator strategy. I count it as a mechanical ventilator strategy because typically we're doing this for vent synchrony, although some of the earlier trials looking at paralysis have suggested that there's an anti-inflammatory effect of the paralytics. But there have been a couple meta-analyses looking at whether or not paralysis in ARDS does anything other than giving them critical illness myopathy. And so this meta-analysis looked at 3 randomized control trials, all from the same investigator group. So you've got to take that with a grain of salt as well. About 430 patients. The trials were pretty different, and so it's kind of hard to pool all of their results together. But when they did this, they found that there was a significant benefit in mortality at both 28 and 90 days. So now we're looking a little bit longer out from these patients and finding that, okay, paralysis might actually be beneficial. That said, this was followed by the ROSE trial that was published in 2019 that looked at about 1,000 patients with moderate to severe ARDS. They gave them either 48 hours of neuromuscular blockade and deep sedation, and compared that to people who were getting usual care versus lighter sedation, and they found that there was no difference in 90-day mortality. And so this was incorporated into the most recent rapid practice guidelines published in ICM that included the ROSE trial and the 3 trials from the other meta-analysis, and then 3 other trials. Again, these trials were so different, so even though they now had 1,600 patients, they basically said, well, the trials are so different that it's hard for us to issue a recommendation, but they suggested using neuromuscular blockade in patients with early to severe ARDS, and this is typically part of our practice. So when we get calls for patients who are in moderate to severe ARDS, who are deeply sedated, even if there's sort of reported vent synchrony, we will generally recommend a trial of paralysis, especially if the next step that we're considering is inserting 2 giant hoses into their groin to remove their blood. So usually we don't even necessarily say that you need to give them sort of continuous, rocuronium or VEC or, Nimbex, but just seeing if a shot of rock or a shot of Nimbex changes their vent compliance at all, changes their vent synchrony, changes their oxygenation. And if it does, then we would say, it's worth a trial of continuous neuromuscular blockade. So what about prone ventilation? So you've heard a little bit about prone ventilation. I'm sure everyone here is familiar with it. We really harp on this because it is one of 2 interventions that has shown such a drastic improvement in mortality in ARDS that barring really any sort of musculoskeletal trauma, significant hemodynamic instability, we essentially will require that patients have had a trial of prone positioning prior to consideration for ECMO. And so why do we insist on this? Well, prone positioning works. I will sort of die on this hill that this is no longer up for debate. It works in the right patients. And that's basically what the data shows. Early studies showed no significant difference, but that may have been an issue of patient selection. And subsequent subgroup analyses of those studies have shown a mortality benefit in patients with more severe disease. So this is the PROSEBA trial that you've heard so much about. 466 patients with moderate to severe ARDS who were prone for 16 hours compared to usual care in semi-recumbent position. And there was a more than 50% decrease in mortality at 28 days, which persisted at 90 days. This is one of the strongest interventions we have in ARDS. The only thing that really compares to this is the low tidal volume ventilation intervention that we found back in 2001. But basically every other intervention we studied in ARDS doesn't come close to this kind of benefit. The important thing about prone positioning is that the details do matter. And so this is a systematic review and meta-analysis from, if I remember correctly, 2017 that included 8 trials of prone positioning, which Again, the pooled results are suspect in that the trials were very different. So you've got to take the pooled results with a grain of salt. And you see that when they pool the results from these 8 very different trials, they didn't really find a significant benefit in that your estimate crosses and your confidence interval crosses the line at 1. And then here highlighted is the ProSiva trial, where you see very significant benefit. So almost a 50% reduction, and so far away from 1 that it's very clear there's benefit in this group. So when they split the studies by whether or not they got lung protective ventilation, you again saw that there was a little bit better sort of signal here in terms of the benefit compared to the non-lung protective ventilation studies, where there was basically no benefit. So this is even further evidence that low tidal volume ventilation is sort of the basic thing that we should be doing for all patients with ARDS, and that when you don't do lung protective ventilation, you don't even see the benefit of anything else that you might do. And this is specifically prone positioning, but this bears out in other interventions in ARDS. And so they also looked at how long people were being prone. So when you looked at patients who were getting prone for longer than 12 hours, there was again a clear signal of benefit here. And the patients who were not prone for at least 12 hours, there was no difference whatsoever. And so this is sort of the detail that I get into on some of these phone calls is, when did they start prone positioning? How long are the prone trials going? And if someone says, oh, they were only prone for 4 hours and we flipped them, we would say, unless there was a contraindication to keeping them prone for longer, that we would give them a real trial of prone positioning. Because not only did ProSiva find that the patients who benefited got longer trials, but that bears out in these meta-analyses. Then they looked at patients in terms of the severity of their ARDS. So moderate to severe ARDS patients, clearly had a benefit. And then when you looked at all ARDS, there was again no benefit. And so again, proning people who are not that sick, you're not going to see a benefit. But in those who are at the sort of clear end of the spectrum approaching needing ECMO, they are likely to benefit from prone positioning. And so how long should we prone patients? I would say, based on most recent data, that there is a limit. And so there was this trial, target emulated trial by one of my friends at Hopkins, looking at whether or not there was a difference between the 16-hour and then 24 hours or longer. They had 314 patients that essentially got split by the sort of target protocol to 234 in the extended group, so 24 hours, versus 80 in the standard group, which was the 16-hour group. And they balanced the group characteristics with some fancy statistics, inverse probability of treatment weighting, and found that there was no difference in 90-day survival. And so this trial suggests that, okay, we should prone people, but we don't need to go crazy. They don't need to be on their stomach for 24, 48 hours. You're not going to get any more benefit after the standard 16 hours. And then one of my colleagues and I were asked to comment on this trial, and the thing that was notable is that there was a lot of heterogeneity in the care of prone patients, and there was a lot more variation in the tidal volume management of the patients who were in the standard group. And so that may have been why they didn't see a benefit, but this is an interesting question, is for the patients who are getting these more aggressive interventions, are we doing better at the smaller things? So are we doing better at keeping them within 6 to 8 cc's? Are we doing better at keeping their plateau pressures under 30? These are questions that still remain to be answered. And so again, as we're evaluating patients, we sort of have our checkbox. Ask about their airway pressures, ask about their tidal volumes, ask about their gas exchange, and make sure that we're still doing the things that matter. And so I'm going to talk about mechanical ventilation on ECMO only in that I'm going to ask the question whether or not we need the ventilator. So there are a number of recommendations about what to do with the ventilator. I apologize that this text is so small, but this is from the ELSO guidelines on what to do with the vent. And they Most notably, focus on maintaining some of your ARMA trial guidelines. So the acceptable range for your inspiratory plateau pressure should be under 30 and ideally under 25. And then PEEP should be, they give you a range of 10 to 24, but ideally greater than 10. And so that is back to that 10, 10, 10 that we heard about earlier today. And these come from the Caesar and Eolia trial, where their strategies for the intervention groups included set parameters for the PEEP, the tidal volume, and with goals for the plateau pressures. But again, if the patient's on ECMO, what if we just got rid of the ventilator? So that's not a bad idea. ELSO actually has great guidelines on how to do this and in whom to do this, and I'm going to focus really on the who. So if you're considering getting rid of the ventilator for patients in ARDS on ECMO, you want to make sure that it's clinically appropriate otherwise. And so these patients shouldn't be in severe shock or in multi-organ failure. You also want to make sure that patients are awake enough to protect their airway, and they're awake enough to cooperate to avoid accidental dislodgement of various devices like their ECMO cannula. And then you also want to make sure that their secretions are manageable without an airway. So we think about the vent as just providing oxygen, but it's also a way for us to do secretion management and secretion clearance with bronchoscopy even if necessary. We also want to make sure that patients have adequate gas exchange. So our goals are typically, keeping the PaO2 above 80 on minimal vent settings and full ECMO support. And then a pH of greater than 735, again, with minute ventilation that's reasonable. So if you need a minute ventilation of 12 liters per minute to maintain basically normal gas exchange, that person may not be able to keep up with that on just ECMO alone if the sweep is already high as well. And then the other things that are not purely respiratory. So patients in heart failure for whom that positive pressure is keeping fluid out of the lungs. If they're in florid heart failure, we may not want to extubate them. And then patients with morbid obesity who may actually need positive pressure to prevent atelecta trauma, we may not want to get rid of the ventilator in those patients either. So how are people actually doing this, and are people even doing this? That's a great question. I'm glad you asked. So this survey from EuroELSO back in 2019 looked at about 250 respondents from centers at which 88% were offering both cardiac and respiratory ECMO support. 71% of those centers were doing at least 15 runs, and about half of them were doing at least 30 runs a year. So these were people who had ECMO experience. And then they were asked whether or not they were extubating patients on VV ECMO for respiratory failure. And about 50% of patients were doing it, respondents were doing that during the run. About 3/4 were doing it after decannulation. And then 12% weren't intubating their patients at all. We're just cannulating ECMO without ever being on the vent. But notably, for the people who were extubating on ECMO, they were doing this for less than 10% of their runs. So this is not that common of a practice, even though people are doing it. And so then they asked, why were they extubating or decannulating first? And so for the centers that were extubating first, they mostly did this to avoid ventilator-associated pneumonias. 28% of them were doing it to avoid muscle weakness. And then 26% were doing it to allow a neuro exam. And that's a little bit confounded by the fact that if patients were intubated, they were given more sedation for sort of comfort on the ventilator. For the people who were decannulating first, so they didn't want to take the vent away while they were on ECMO, about a third were doing it to avoid anticoagulation, and then about another third were doing it to avoid patients being awake and potentially messing with their ECMO cannulas. And so so there's been some research in how to approach extubation in patients on ECMO. And so in this study that looked at about 250 patients, around 4 ICUs, these patients were almost exclusively VV ECMO cannulated. I think there were 3 patients who were VA or VPA. They had these patients targeted to wean their sedation for a RASS of -1 to 0, and then they were doing daily assessments of clinical and gas exchange criteria. This flow chart is just showing you how patients fell into the 2 groups, and they looked at whether or not patients, there was a difference in ventilator-associated pneumonias between patients who were kept intubated and patients who were extubated while they were cannulated. And there was a significant difference in the incidence of ventilator-associated pneumonias. So getting rid of the ventilator on ECMO might actually help us avoid this harm. There was a difference in the rates of hemorrhagic shock. So patients who were extubated first had less hemorrhagic shock than if they were decannulated first. There was a difference in the rate of cannula-associated DVTs. So, of course, patients who were on ECMO, with the tube out, were more likely to get a cannula-associated DVT. And then finally, there was really no difference in the rates of accidental decannulation. So that concern about patients being awake without the ventilator wasn't really borne out in this study. And then just looking at some other questions about harm reduction. So in terms of differences in mortality, there was a significant difference in mortality for patients who were extubated. So they were less likely to die if they were extubated while on ECMO. They were also less likely to get a trach if they were extubated while on ECMO. There was really no difference in the ventilator-associated pneumonia rates when they did very fancy statistical adjustments. And then there was maybe a difference in nosocomial infections, which does not include ventilator-associated pneumonia. So these are like CLABSIs, other sorts of infections. And then finally, does getting rid of the ventilator while they're on ECMO lead to a survival benefit? And the conclusion here was there might actually be a survival benefit to taking the ventilator away when patients are on ECMO. And so it's interesting that we can do all these things on ECMO or before ECMO with the ventilator to improve people's survival, but once they're on ECMO, it might actually be better to forget the ventilator entirely and take it off. We're not there yet as a sort of general management practice, and so we are typically still doing all of the things that I talked about in terms of managing patients on ECMO with those ventilator practices. But it's an interesting question that I think we're moving towards. And for some patients, we are actually pro-extubate while on ECMO. So our status asthmaticus patients, patients who are bridged to transplant, which is a completely separate talk. But it's we're not there in terms of doing it for everyone. And so sort of finally, I want to really close by saying that the importance of ventilator management pre-ECMO really is tied to selecting patients for ECMO. So when patients don't get optimal care on the ventilator prior to being referred for VV ECMO, that does actually impact their candidacy, and that's something that we try to educate our community about whenever we get referral calls, because it really is a continuum of care. It's not just the patient failed mechanical ventilation no matter what we were doing, and now they need ECMO. It's like, well, they unfortunately had, suboptimal care on the vent before being referred for ECMO, and that unfortunately impacted their candidacy for ECMO. And so this is from that ECMO from salvage to standard of care paper, where for patients with meeting moderate to severe ARDS criteria, that algorithm includes all of the things that we just talked about. So prone positioning unless contraindicated, neuromuscular blockade, high PEEP strategy, which I didn't talk about, And then these two are a little more controversial because recommendations have recently changed for them. But inhaled pulmonary vasodilators, which we only use for transport stability. So we will use nitric or Velitri to get a patient from a referring hospital to our center. But once they get to our center, if they can't tolerate being taken off of the inhaled vasodilator, that's essentially a sign that they need extra oxygenation support and probably need ECMO. And then once they're on ECMO, we take it off completely. And then we do not use recruitment maneuvers. That again is that to us is a flag. Like if you're reaching for a recruitment maneuver, you should probably also be reaching for an ECMO consult. And so I think that's all I have. So thank you, and I'm happy to take questions.
Thank you for this excellent presentation. One question, perhaps?
Hey.
You showed a stat earlier regarding patients on ECMO who are not on mechanical ventilation. I'm just curious what population of patients that is.
Patients on ECMO who are not on mechanical ventilation, who are never cannulated. So we have had patients with pulmonary hypertension who we will cannulate without intubating, especially given the severity of their pH. You're worried about the positive pressure inducing cardiac arrest. So they'll be cannulated under moderate sedation. We have had pregnant patients who get cannulated without intubation. And those are probably the two main populations, I would say, but it's a very uncommon thing. Most patients are intubated, if for nothing else, for sort of procedural sedation to tolerate cannulation, but yeah.
You talked a lot about proning. Have you had any success for using any of those new standing beds now instead of proning?
No, so we do not use any of the sort of like rotaprone or any of the... Oh, yeah. So we don't use that in place of proning. So we'll use those for mobilization, but not as a substitute or an adjunct to proning necessarily. We're still manually flipping.
Thank you again. It was excellent.
Thank you.